Hey guys, so this is the video for head and neck cancer for chapter 29. And just remember that most head and neck cancers are going to be slow growing, usually squamous cell carcinomas that are curable in the early stages. And table 29-1 gives us symptoms to look for, and they include pain, changes in the mouth that are color based, and then lumps, oral lesions, bleeding, difficulty swallowing, numbness in the mouth, lips, or face, changes in denture fit, unilateral ear pain, sore throat, shortness of breath, anorexia or weight loss, and burning sensation in the mouth and throat when patients drink citrus based fluids and hot liquids. So for head and neck cancer, our priority is going to be the airway and gas exchange. So we also want to keep an eye on our patients' kidney and liver function tests, because that will let us know if the cancer has metastasized to that area. As far as treatment, there's going to be a small cell and non-small cell cancers, and for small cell, radiation is going to be the go-to. We want to teach our patients about the side effects, dysphagia, skin problems, impaired taste, hoarseness, xerostomia, dry mouth, which can lead to tooth decay, and they can use fluoride trays for that. And then also with adjuvant therapy, as far as the chemotherapy, they should really avoid breaks in chemotherapy and try to finish it out as the doctor has planned for them. And then as far as surgery, and I'm just going over real basic stuff, just really basic review. So as far as surgery, that's going to depend on the tumor size, the node number, the if it's metastasized, and where it is. So that'll determine the type of surgery for those patients. And then the surgeries can include a laryngectomy, a tracheotomy, or a oropharyngeal resection. For pre-op teaching, I'm going to focus a lot on teaching because I feel like that's where a lot of our test questions come from. So for pre-op teaching, we want to teach the patient about self-management of their airway, suctioning, pain control. We want to teach them about what the critical care environment is going to be like, especially with the ventilator. And then we want to teach them about the different feeding tubes that they might require, whether it's PEG or NG tube, whatever the case may be. And then we also want to go ahead and start planning for discharge before we've even done the surgery. So, and then another key thing is to determine a method of communication, because if they're on a ventilator, they're not going to be able to communicate. And depending on the surgery, even if they're not on a ventilator, they're going to have trouble talking. So there's a chart in chapter 29 that gives you all kinds of, it gives us a lot of different ideas as far as different ways we can communicate with them. So check that out. And then also for the actual operative process, they can have a partial laryngectomy. And with that, the trach is usually temporary. But with a total laryngectomy, the trach is permanent. So, and then with a neck dissection, they're probably going to have a shoulder drop because they've removed like the sternocleidomastoid and all the accessory muscles here. So that should be kind of explained to them ahead of time as well. And that can be corrected or at least managed with PT. For post-op, we want to maintain airway patency. We want to take vitals hourly for the first 24 hours. And then we want to keep an eye on their hemodynamic tests and then also keep them comfortable and their pain level as low as possible. And then with the ventilator, we want to let them know with weaning, once we get them on a trach collar, that the blood tinged secretions for the first 1 to 2 days is normal. That's something we're going to expect. And then when we're teaching them suctioning, we need to make sure that they know to suction away from their surgical site. And then this is in a box in chapter 29, very important box. If a patient has skin grafts or flaps, the first 24 hours is critical, and those need to be evaluated, the flaps and skin grafts, hourly for the first 72 hours. If we suspect that there is a rupture, which I hope never happens to any of us, if we suspect leaking, don't touch it. Don't touch it, because you can rupture it and make things so much worse. So, suspected leaking, don't touch it. If it's an actual leak and blood is spurting out, then you can touch it and apply pressure to the carotid and prep them for emergency surgery. And you stay with them and you keep your hand on their carotid with pressure, because they could bleed out. I'm sure we all know that. So anyway, actual leak, you can touch it. Suspected leak, you're not allowed to touch it. So and stay with your patient. Regardless, stay with your patient. You're not allowed to leave them alone. Another thing with the total laryngectomy, they're not able to aspirate. So if it's a partial, you're going to watch them really closely for aspiration. But if it's a total, then they can't aspirate. It's impossible. So with speech, there are several different ways we can attack that area. So there's esophageal speech, which is the speech that is like burping. And then the electropharynges is the like electric voice box that they hold up, and they can use that to talk. And then there's the TEP with the voice button. So 3 different types of communication we can figure out just depending on which surgery they've had. Also, for teaching, we need to teach them about tube feedings, whether they have a G tube, J tube, gastric tube, whatever the case may be. Sorry, I'm saying that a lot. I'm really tired. So, and then we also need to teach them stoma care, wound care, and trach care, just depending on what they're going home with. And then we also want to make sure they know to stay well hydrated and increase humidity. That's a good thing for them to do, to keep everything fluid. We don't want anything drying out. And then also that we expect them, depending on the extent of their cancer, to be able to return to normal activities within 4 to 6 weeks, for just in general. And then I think that's pretty much the bulk of it. There's some other boxes in chapter 29 that sum up care fairly well. So I just kind of went over basic stuff. But I hope that was helpful. Thanks, guys. Bye.